Good afternoon, everybody. At the outset, I must thank Dr. Sanjay Kumar for inviting me here back to my hometown, and thank you, chairpersons, for those kind words of introduction. Can I have my slides, please? So, I'll be talking about acute on chronic liver failure, and I bring greetings to you from St. GS Medical College and KEM Hospital. We have a wonderful faculty there, and also greetings from Department of Hepatology at Sir H.N. Reliance Foundation Hospital. So, what is the basic concept of ACLF and ALF? You have a normal liver where you get an acute insult on the liver and the liver fails. This is acute liver failure. You have already an abnormal liver, a pathological liver for a long time, and on top of it, you get an acute insult, and then the liver fails. This is called as acute on chronic liver failure. So this is the basic difference between the two. The key thing here is the liver has to fail. How do we define the liver failure? How do we define the acute insult? We will see in the next few slides, and why we require this concept. So the key components are that there should be a rapid deterioration of the liver function. That is what we see. And these patients develop not only liver failure, but they also develop failure of other organs subsequently. So it starts off with liver, but then you will have other organs involved, and that is why these patients have a very high risk of mortality. So the APASL definition is you have acute insult of the liver which manifests as jaundice and coagulopathy. So you should have a bilirubin more than 5 and INR of more than 1.5. And this should be complicated within 4 weeks with the development of ascites and or encephalopathy. The diagnosis of the previous chronic liver disease may have been there or not there, but the liver disease should be present. And this is associated with a high mortality at 90 days. The Europeans have a slightly different definition, but the concept remains the same. It is an acute deterioration of a pre-existing cirrhosis because of a precipitating event and increased mortality at 3 months due to multi-organ failures. So this is very important for us to understand. What is the difference between an acute decompensation and an acute on chronic liver failure? These are again two different terms. So in acute decompensation, there is a new decompensating event. What is the new decompensating event? It could be ascites, it could be GI bleed, or it is encephalopathy. Something which has not happened before and now happens for the first time. First time ascites, first time GI bleed, first time hepatic encephalopathy. These patients do not have deep jaundice. There is no liver failure as such in these patients. So no significant derangement of INR, no impact on other organs, and these have better prognosis than ACLF. So differentiate between acute decompensation and acute on chronic liver failure. And very often you will find that the acute decompensation is because of the natural progression of the disease. There may not be any identifiable decompensating insult which is causing this. What can be the insults which precipitate ACLF? It could be a liver-related insult like reactivation of hepatitis B, alcohol, hepatitis E, a drug which is taken which is hepatotoxic, autoimmune hepatitis flare, Wilson's disease flare, or it could be a non-hepatic but liver-directed insult like a surgery or a trauma or a systemic viral infection like dengue, or it could be infections. It could be a GI bleed which has precipitated multi-organ failure or active alcoholism in the past. Then you could be also because of a major surgery, because of a therapeutic paracentesis causing PICD. All these can also precipitate ACLF. The key thing as we discussed was that these patients are at risk of developing organ failure, and that is why we need to recognize this entity very early. The organ failure typically starts off with the liver where the bilirubin is high, but can also involve the kidney. The creatinine can go up. It can affect the brain. So hepatic encephalopathy requiring grade 3, grade 4 also sometimes. Coagulation abnormality, so the INR is often deranged, usually beyond 2.5 in severe ones. And circulatory, that is cardiovascular failure, where there is increased need of vasopressors because of progressive hypotension. And the worst and the most detrimental organ failure is the respiratory failure. You have a patient with ACLF who's having respiratory failure. The PO2 FiO2 ratio is falling to below 300 and then below 200. This is associated with the worse outcomes, and this is also the group of patients where even transplant may not help. So we have to identify patients before they develop these organ failures so that we can treat them appropriately. So based on the number of organ failures, 1, 2 or 3, you classify them as ACLF grade 1, grade 2 or grade 3. Similarly, the ARC has defined based on bilirubin, hepatic encephalopathy, INR and lactates and creatinine. So the key thing, one message if I have to give is, if you have a patient who has come with sudden worsening of liver disease, please look at their lactates. If the serum lactate is high, this patient is going to have complications and affection of other organs. So this should be part of your tests which is sent on admission or from the emergency room itself. The moment a patient comes with worsening of liver function, one test which you should send for is lactate. Once you correct the hemodynamics, repeat the lactate. If the lactate is rising, this patient has very poor prognosis and should be immediately managed at a center which is used to managing patients with acute and chronic liver failure. Look at the mortality. With just one organ failure, the mortality is 20%. If it goes to 2 organs, 30%. And grade 3 ACLF has more than 80% mortality in the next 4 weeks. So this is the risk that we are talking about. And can we identify them early? The answer is yes. If you look at the natural history of ACLF, the first 1 week is the golden period. Within the first 7 days, the insult is usually restricted to the liver. You do not have SIRS at this stage. The gut dysbiosis, the bacterial translocations have not yet started. Just the beginning of gut dysbiosis. So no bacteremia, no sepsis. If you can intervene in this first week, it changes the outcomes. You can reverse the acute insult, you can prevent the progression, and you can save lives. Once you go into the second week, that is when SIRS develops, you start seeing immunoparalysis, and finally that leads to sepsis and septicemic shock. And that is when you start seeing failure of other organs, the kidney, lung, brain, circulation. And that is when it may be very difficult to salvage the patients. So the key is to identify these patients early in the first week itself. So this is called as the golden window, 1 week before the onset of sepsis and development of extrahepatic organ failure. And this period gives you an opportunity for immune modulation to improve the patient outcomes. So does it mean that we can reverse the changes that are there in ACLF? The answer is yes. With timely mitigation of acute insult, the hepatic reserve can actually improve, even the fibrosis can regress, and the portal pressure can decrease. 70% of survivors at day 90 show reversibility and maintain this status for more than a year. The reversibility is defined as reversal of bilirubin coming down below 5, INR coming down below 1.5, and no HE with or without resolution of ascites. So you can actually reverse ACLF if you manage them early and manage them well. Once they develop organ failure, this is Indian data, you can see with ACLF3, the risk of mortality is more than 80%. So this is from our own population. Once the number of organ failure is 3 or above, it is very difficult to salvage these patients without transplant, and even with transplant, these patients will have worse outcomes as compared to others. So how do we really approach these ACLF patients? So you admit them in an ICU, nutrition, treatment of precipitating event, treatment of infections, support of failing organs, and liver transplant in the right candidates. So for every organ, you have a specific strategy. So you look at the problems which you are aware of, you're familiar with, and you have a specific intervention targets for this. Nutrition is of paramount importance. You have to ensure calories. Very difficult to feed these patients orally, and very often you'll have to put in a nasojejunal tube or a nasogastric tube to feed them. Do it on the first day. Do not delay it. Try for 3-4 days. The patient's acceptance also for a nasogastric tube, nasojejunal tube is maximum if you put it on the first day. If you try for 2-3 days and then try to tell them once they're familiar with the environment, usually you'll get a negative consent. So put the trials tube on the first day itself, and parenteral feeding should be avoided as much as possible because you can actually worsen the liver function, especially if you have lipid-based formulations. So then if you are giving parenteral nutrition, it has to be non-lipid-based formulation. So, and you must give a late night feed. So use trickle feeds during the night. That will help improve the outcomes in your patients with ACLF. So give them very small 20-30 ml per hour feed, which goes on even during the night time. Treat the precipitating events. For hepatitis B, you have nukes which you can use, and at day 15, look at whether the DNA levels have fallen down or not. If the DNA levels have fallen down on day 15, good chance that this patient will survive without a transplant. For alcoholic hepatitis, precipitating as ACLF, in early stages, you can still think of giving steroids if you have a biopsy-proven severe alcoholic hepatitis. Do not give steroids empirically to these patients. There is a high risk that you will precipitate sepsis, or if there is just a natural progression or a non-hepatic insult, then you will actually cause more harm to the patient than benefit. And of course, those patients who do not respond, you can offer transplant, or you can go for experimental therapies like FMT. So, what about autoimmune hepatitis? So, can we give steroids in those patients who present with ACLF and autoimmune hepatitis? The answer is yes, you can if you start it early, and in those patients who still have not developed advanced encephalopathy or advanced coagulopathy. So, if the INR is still in the normal range, maybe around 2, 2.5, if the encephalopathy is only grade 1, then you can still give steroids, but these patients should be parallelly waited for transplant. If the patient doesn't improve in the first 5 to 7 days, then you must transplant them. Do not waste more time. So right from the first day, while you are starting steroids, you keep your option of transplant open, start working up. In 7 days, if the patient improves, good. Doesn't improve, your transplant is ready. Bacterial infections is a major problem, present in almost 1/3 of patients at presentation itself. And if you follow them up for 2 weeks, almost everybody would develop if they have a progressive disease. And it predicts the development of organ failure. So we have to be very aggressive, frequently send cultures, start empirical antibiotics, and you must keep on doing cultures and change your antibiotics according to what you grow on cultures. Fungal infections is another major problem in these patients. And if you have a patient with sepsis who is not responding within 48 hours, suspect that there could be a fungal infection. Very often, we will start empirical antifungals in patients who are worsening rapidly. We can use galactomannan or beta-glucan, but they're not very reliable. We have to support each of these organs with specific therapies, and it is beyond the scope to discuss this entire thing, but there are golden principles for management of each of these organs. And while you're reversing the acute insult, you can offer therapy for each of the organs and buy time for either transplant or for spontaneous recovery. So if you have a specific therapy for etiology, you offer it. If the patient has extrahepatic organ failure and patient is not improving in the first 4 to 7 days, then these patients should go for transplant. While we do a transplant, it's not going to happen the next day. You decide today and tomorrow transplant will happen. You have to bridge these patients. So in the absence of liver transplant, bridge therapy is available for bridging these patients, which includes either plasma exchange, liver dialysis, which is like Mars, SPAD, Prometheus, or now what we use CRRT very routinely in those who have high lactate levels, severe encephalopathy, and other complications. And there are bioartificial liver devices which are not widely available. Transplantation is something which has changed the way we look at these patients. It has improved the outcomes in a lot of patients. Patients who are on 3 inotropes, patients who are in sepsis which is uncontrolled, patients who have a lung infection, patients who are on ventilator and requiring high supports, high FiO2, they are not the candidates for transplant. Those are the patients where you should not transplant. You have already missed the window. Please do not offer transplant to them. The outcomes of transplants are excellent in ACLF patients. Now, very often we are doing also simultaneous liver kidney transplant in patients with ACLF if the kidney is unlikely to improve, especially in patients who are diabetic and also have diabetic chronic kidney disease. So to summarize, my dear friends, we have several definitions, but they are complementary rather than competitive. The outcomes of ACLF is determined by the severity of liver failure and extrahepatic organ failure. Please look for these patients in the first week, the golden window. Treat very aggressively in this first week. The basics of critical care are of paramount importance, especially the nutrition. The acute event should be treated wherever possible and reversible, and liver transplant remains the most definitive therapy for patients with severe ACLF. Thank you very much. I'll be happy to have questions.
Thank you, sir. Thank you for the excellent lecture. You have given the elaborate description of the topic, what has been assigned to you. See if there is any question, one or two quick questions.
Yeah, Akash, quickly I would like to know your experience of PLEX in patient with ACLF. I mean, we have had some patients who in fact deteriorated after PLEX. Some of them do have improvement in terms of decrease in bilirubin, but no other improvement. The other thing I wanted to know is the policy, antibiotic policy for ACLF. Do all patients you start antibiotics? It is said that if any cirrhotic is admitted for any reason in the ward, you start them on antibiotic. Is that true?
So I think with regards to PLEX, I think it is not something which can be used indiscriminately. So there are some certain conditions, certain situations where you would never use plasma exchange. So you don't use it if the patient is in fluid overload, if there is pulmonary edema, if the patient is in ARDS. These are the patients where PLEX can actually cause more harm. Second is, if the patient has already got an infection, then these patients are going to worsen. Those patients where you are not sure that there is no infection, please do not offer PLEX, because we know that plasma exchange, despite whatever the literature says, in real life, plasma exchange is associated with increased risk of sepsis. So we would offer patients with ACLF PLEX, one, if they have hemodynamic instability, two, which basically means they're requiring inotropes, and they have tachycardia, and we know it is because of SIRS and not because of sepsis. So only in those patients we would offer PLEX, and also when I have a definite option of transplant, I know that in next 5 days or 7 days I'm going to transplant this patient, then it makes sense to do plasma exchange. We should not do plasma exchange indiscriminately in these patients. It's a bridging therapy. It's not a definitive curative therapy for ACLF. With regards to second question about antibiotic policies, so ACLF 1, do not use empirical antibiotics, but ACLF 2 and 3, till we get culture reports, we would offer antibiotics empirically. And again, don't start with very high antibiotics empirically, unless you are suspecting sepsis. If there's a suspicion, yes, depending on your culture sensitivity, but as a prophylaxis, please do not start with the highest possible antibiotics.
It was an excellent talk, Dr. Akash. I would like to talk little about acute and chronic liver failure related to alcoholic hepatitis, because in clinical practice, we all face, that is the most common type of acute and chronic liver failure, severe alcoholic hepatitis. So, two issues, major challenges we face in clinical practice. One is, as you discussed, we should not start steroids without a biopsy report. They are already in coagulopathy, so generally percutaneous biopsy is not feasible in these patients, so we have to do transjugular biopsy. So one thing comes under B grade cities is availability, and second is cost, certainly to the patient. And second thing, how often steroid works, because mostly we face, we are stuck. If steroids has caused infection, we are stuck so that we cannot subject the patient for liver transplantation also. So that is that are the two major challenges we face.
Excellent questions, excellent points which you have raised. So patients with severe alcoholic hepatitis, there are certain patients whom you will never consider for steroids. Patients who have already got a significant renal dysfunction. So those are the patients where you would not offer steroids. Patients whose DF is already more than 100, in those patients the steroids are not going to work. So in the sickest lot, you don't really talk of steroids. So steroids is something which you're going to offer when the patient has come to within the first 2 weeks or 3 weeks, not beyond that. Once they have established full-fledged liver failure, other organ failures, those who are already in ICU, there we have already missed the boat for giving steroids. So steroids is for somebody whom you have seen in the OPD and you are admitting because you want to manage severe alcoholic hepatitis, not when you are when you are trying to manage other organ failures. I agree that there is a problem of cost and availability, but I would strongly recommend avoid using empirical steroids. If at all you are going to treat empirically, I would still say, despite the STOPA trial, that pentoxifylline is a good drug, and you would, especially in patients who have got renal insufficiency, you would offer these patients pentoxifylline rather than steroids. Why? We can talk over the lunch, why I am saying pentoxifylline even now, but I think in those group of patients, pentoxifylline still works.
Akash, I have one question.
Sir.
How much importance do you attach to the so-called neutrophilic lymphocyte ratio for deciding about steroids? Less than 5, between 5 to 8, or beyond 8?
Yes, sir. So that is very important parameter that we see on liver biopsy. It has to be a neutrophilic pattern.
No, I am talking about just a count.
Oh, the systemic one.
Systemic one.
So for decision to treat, no, but prognosis, yes. It's a very, very important feature for prognosticating the patients.
Sir, place of GCSF in the management of all these conditions, sir.
So for ACLF, there was one positive trial from New Delhi which showed that there is good response, but there is a negative trial which is multicentric European trial for GCSF. So that is why as of now it is not recommended by any of the guidelines, and therefore it cannot be used beyond the purview of clinical trials.
And since these patients have got a recurrent history of hospitalization, sir, and since we are getting a patient that they have accounts of 23,000 like that, and they are coming with hepatic encephalopathy grade 3. So what do you suggest? Shall we go with the piperacillin, trazobactam or meropenem as an empirical therapy for the first line?
I think again very good point. So whenever we decide the antibiotics, there are certain things which we look at. And one of the things which you very appropriately said is how many times patient has been previously admitted. So if the patient has had repeated admissions, repeated exposure of antibiotics, you would probably start, and you're suspecting a sepsis, you would probably start off with a combination which will be a carbapinem and probably one more drug. But very important that if you're starting off with a higher antibiotics, before you give the first dose of antibiotics, send cultures and be aggressive in de-escalating. You should trust your cultures, and if the cultures come negative, then you should be ready to de-escalate. If you start off with a higher antibiotic and despite culture you are not going to de-escalate, then don't send the cultures. Then it is a waste.
Thank you, Dr. Akash. And due to time constraints, we can have further discussion during the lunch time.
Thank you.
Thank you, sir.